Hi students, this is a quick review of Chapter 15, the cardiovascular system. So a little intro is that the heart pumps out 7,000 liters of blood throughout the day. Know that we only have 5 liters of blood though, so you guys can do the math on how many times those 5 liters is circulated throughout the system. On an average lifetime, which is in around somewhere in the 70s, the heart contracts about 2.5 billion times. And the order of blood vessels would be from the left ventricle to your big arteries, then to your smaller arterioles, then to the capillaries, and then it gathers back again into the venules, veins, and then back to the heart to the right atrium. The cardiovascular system is made out of 2 parts: the cardiac part, which is the heart, and the vascular part, which would be your blood vessels. So in this chapter, we're going to be talking about both. First, a little overview of the cardiovascular system. The function of the heart is obviously to pump the blood into your blood vessels, and we have a couple of different circulations or circuits. There is the systemic circulation and the pulmonary circulation. So the pulmonary circulation is the heart that has the deoxygenated blood or the oxygen poor blood, and it's pumped from the right side of the heart to the lungs, where it would get the oxygen, and then that blood that is now full of oxygen will be collected onto the left side of the heart, and then it'll get pumped to the rest of the body through the systemic circulation. So your systemic circulation transports the oxygen-rich blood, or what we call oxygenated blood, from the heart, in particularly the left side of the heart, to all of the cells of the body. You can see here a little image here that shows the pulmonary and the systemic circulations. That right here is the heart. This is the right side of the heart. There's the right atrium, right ventricle, left atrium, and left ventricle. And you'll see that the pulmonary circulation, for the most part, is made out of venous blood. That's why you'll find that the blood vessels are blue. So the venous circulation, all of the venous blood is collected from the upper part of the body and the lower part of the body into the inferior and superior vena cava. And all of that is dumped into the right atrium, goes down into the right ventricle, and then pumped from the right ventricle to the lungs. It's in the lungs where it gets its oxygen, and then all of that oxygenated blood in these red blood vessels are going to gather into the left atrium. This is how we're going to start now the systemic circulation, where the oxygen, so all of that oxygenated blood that is now gathered into the left atrium will get pumped into the left ventricle, and then from the left ventricle into the aorta, and then to the rest of the body, whether the upper or the lower parts of the body. And that would make your systemic circulation. So here again, you can see the difference between pulmonary and systemic circulations. The pulmonary circulation is made out of the deoxygenated blood. It all starts by the blood gathering into the right atrium and then passing through all of these blood vessels until it reaches the left atrium. In the left atrium, now we're going to start your systemic circulation, and that what is now oxygen-rich blood is going to get pumped from the left side of the heart to the rest of the body. And here you can see the whole process of oxygenation happening. So this right here is an alveolus, or an air sac, and it is surrounded by that capillary. Between the capillary and the air sac, there's a little space, and that space is known as interstitial space that has a little bit of interstitial fluid, so you can see some of the water molecules there. Now the blood coming from the right side of the heart, as we said, is deoxygenated or venous blood, and as it passes through this blood vessel, there is exchange of gas where carbon dioxide diffuses from the blood vessel into the alveolus, and oxygen diffuses in the opposite direction, where it goes from the air in the alveolus into the capillary, and the blood emerges on the other side as now oxygen-rich or oxygenated blood. Now all of that oxygenated blood again is going to gather up into the, be dumped into the left atrium through 4 pulmonary veins. So we'll talk first about the heart, which is the muscular pump. It is found in the thoracic cavity, in the mediastinum, right in between the 2 lungs. It is right on top of the diaphragm, and it's got 2 chambers on the top. Those are known as your 2 atria, and 2 on the bottom, known as the ventricles. Right here, this shows the triangle, the heart kind of looks like a triangle where there is the apex of the triangle is found in the 5th intercostal space. 5th intercostal means the space between the 2 ribs, and 5th intercostal would be between the 5th and the 6th rib, while the base of that triangle is all the way up here, and that is found behind the 2nd rib. And you'll see that obviously the heart is, although it is behind the manubrium sterni, or the sternum, it is a little bit shifted to the left so that the apex of the heart is felt and heard on the left side. Now the heart is a very important organ, so it has lots of different coverings. All of these coverings together are known as the pericardium. There are 3 different layers of the pericardium. So if you guys remember when we talked about the serous membranes, we mentioned that there is a visceral and a parietal layer of the pericardium. So that right here is your cardiac muscle, or the myocardium, and that would be your visceral pericardium. And then it reflects back to become the parietal pericardium. And that space between them, we call that the pericardial space, that has a very, very small amount of fluid known as the pericardial fluid. Now, surrounding or superficial to the parietal pericardium is what is known as the fibrous pericardium. That is it's made out of dense connective tissue, and all of that is surrounded by fat. Again, like I said, that the heart is an important organ, so you have several layers covering them. Now, if you dissect, if you remove that pericardium, you want to take a look at the layers of the heart. There are actually 3 layers. The layer on the outside is known as the epicardium, which is actually your visceral pericardium. So the visceral pericardium and the epicardium are the exact same layer. And then deeper to that, you have the thickest of all 3 layers, and that's the myocardium, made out of cardiac muscle. And then the innermost layer, that's known as the endocardium, and it's a smooth layer, and it lines the inside of all of the chambers, and it's continuous with the blood vessels as well. But in the blood vessels, we are going to call this the endothelial lining. The chambers and the valves, we have the 2 upper chambers. Those are your 2 right atria and the right ventricle. The ones on the bottom are known as the ventricles, right and left ventricle. And then there are also auricles. Auricles kind of look like these 2 little flappy extensions that are attached to the atria. They are continuous with the atria, and those allow for the atrial expansion. So we want to take a look at the valves. So right here you can see an image where the heart is open, and again here's your right atrium and right ventricle, and in between those 2 chambers you're going to find a valve that has 3 gates or 3 cusps, and that is known as the tricuspid valve, while the valve between the left atrium and the left ventricle is known as the mitral or the bicuspid valve because it has 2 cusps. The tricuspid valve will allow blood to go from the right atrium down into the right ventricle, but it prevents blood from flowing in the opposite direction. As for the mitral valve, it allows blood to go from the left atrium into the left ventricle, but it'll prevent blood from being pumped in the opposite direction. Now, as the blood gets pumped from the right ventricle into the pulmonary trunk, there is a valve there, and that is known as the pulmonary valve, so it'll allow the passage of blood from the right ventricle into the pulmonary trunk, but it'll prevent it from going back. And then the last but not least valve is the valve between the left ventricle and the aorta, and that is known as the aortic valve. Again, it allows for the passage of blood from the left ventricle to be pumped into the aorta, but it prevents the regurgitation or the blood from returning back into the left ventricle. So you want to be familiar with where or the position or the location of each of these valves and what is the function. So it'll allow blood from which chamber to what other chamber or blood vessel and prevent it, from going in the opposite direction. So the blood flow through the heart will obviously start in the systemic circulation, and then all of these veins and venules are going to gather to become your superior and inferior vena cava. All of that will dump the deoxygenated blood into the right atrium, then down through the tricuspid valve into the right ventricle, up into the pulmonary trunk, and then into the right and left pulmonary arteries. Know that although this is a blue blood vessel, but it is called an artery. Artery and vein really, they're obviously not color-coded in real life, but they are named according to the direction of blood flow. So if the blood is moving away from the heart, it's known as an artery. If a blood vessel brings blood towards the heart, that would be considered a vein. So regardless of what the blood is, whether it's oxygenated or deoxygenated blood, that's now not how we name blood vessels. We name them according to the direction of blood flow. Okay, so pulmonary trunk to the pulmonary arteries, where again it gets oxygenated in the lungs, and then these pulmonary veins, 4 of them, 1, 2, and then 3, 4, will dump that now oxygenated blood into the left atrium, down the left ventricle through the mitral valve, and then from the left ventricle pumped into the aorta, and it has to pass through the aortic valve, and then the blood, the oxygen, carrying now oxygen, is going to be transmitted to the upper and lower parts of the body. Now the heart also has a skeleton. It's obviously not made out of bone, but it's made out of dense connective tissue, and it's found around the valves, and it prevents the over distension of the chambers. Now the first thing the heart does as soon as the blood is pumped into the aorta, it gives out these 2 branches, the right coronary and the left coronary arteries. And those are obviously going to branch off into other blood vessels, and those are going to supply the myocardium itself. So the heart obviously has to get its own oxygen before it can, in order to function and pump blood to the rest of the body. So the coronary arteries are the first 2 branches off of the aorta. Now for the cardiac cycle, so we want to talk about the different heartbeats and, which which chambers contract at the same time. So we'll give a little talk about, a little background, that the atria contract together as one unit, while the ventricles contract together as a separate unit. So your atria would contract together, and those are known as atrial contraction or atrial systole, and the ventricles will contract together, and that would be known as ventricular systole. Atria and ventricles cannot contract at the same time. Okay, so when the atria contracts, it's trying to push blood into the ventricles, so the ventricles have to relax in order to receive that blood. It would be useless if both chambers were contracting at the same time. Okay, so at the time when there is atrial contraction, there would be ventricular diastole, which means relaxation. And the opposite is correct. When the ventricles are contracting, the atria would be relaxing. Ventricles are going to be dumping the blood, pushing the blood, whether into the pulmonary or trunk or into the aorta, while the atria would be relaxing and collecting the blood from the inferior and superior vena cava if we're on the right side, or from the 4 pulmonary veins if we're talking about the left atrium. So the cardiac cycle, again, this cycle obviously happens, there's no real start and finish to it because it's always happening. And in order to explain it, we have to kind of break it down. So we'll really start at atrial systole. During atrial systole, the ventricles are relaxed or are undergoing ventricular diastole. The AV valves have to open, okay, whether we're talking about the tricuspid or the mitral valves, both of them together are known as the AV valves or the atrioventricular valves. have to open, while the semilunar valves, which are your aortic and pulmonary ones, are going to be shut. Okay, when these AV valves open, by gravity, about 70% of blood will actually flow from the atrium down into the ventricles. The remaining 30% is going to be pumped by the actual contraction of the atrium. Now when we come to the next step, which would be ventricular contraction, so when the ventricles need to contract, which is on this side, you have to the heart is going to have to shut these atrioventricular valves, the tricuspid and the bimitral valves. So the ventricle is going to contract and it'll pump the blood into the aorta. So you have to open up these aortic valves or your semilunar valves. The atria is undergoing diastole and it'll start collecting blood from the veins. Now the heart sounds, we hear those using a stethoscope, and it sounds like a lub-dub sound. Those are the sounds of the closing of the heart valves. Okay, so when the heart valves shut, that's the sound you're hearing. You do not hear the sound of valves as they open, unless they're squeaking or malfunctioning. But normal sounds that we hear are due to the closure of your heart valves. The lub is your first heart sound, and that's due to the closure of the AV valves, your atrioventricular valves, and that happens during ventricular systole. The dub sound, that's your second heart sound, and that is due to the closing of the semilunar valves, your pulmonary and aortic valves, and that happens during ventricular diastole. An abnormal heart sound is known as a murmur. That is due to the incomplete closure of these valves, where you can hear now the blood kind of flowing in the wrong direction. That is known as regurgitation, where it's returning back where it shouldn't be. That heart sound is known as a murmur. So where do we put the stethoscope in order to hear the four valves? So the best area to hear your mitral valve will be in the fifth intercostal space, on the left side, okay, mid-clavicular line. Mid-clavicular line means if you make a line starting in the middle of the clavicle and go all the way down until you reach your fifth intercostal space on the left side, that would be the area best to hear your mitral valve. The tricuspid valve, or the tricuspid area, is heard best in the picture is showing the fourth, but it's really the fifth intercostal space. In what is on the left side, in what is known as the parasternal line, so the line that is parallel to the sternum. The pulmonary and the aortic valves, those are heard in the second intercostal space, parasternal lines. Your aortic area is on the right side, while the pulmonary area is on the left side. Now for the cardiac muscle, remember we talked about the cardiac muscle when we were talking about the different kinds of muscle fibers. We said that they're intercalated discs between the muscles. The muscle fibers are branched out. There's gap junctions, and those intercalated discs with the gap junctions allow for the fast transmission of the electricity or of the action potential, so that the heart can contract as a unit. Each functional unit is known as a functional syncytium. So we have the atrial contracts, both atria contract together, but we call that the atrial syncytium. And then both ventricles are going to contract together, and that is known as the ventricular syncytium. In order for the ventricles, or in order for the heart to contract, we need electricity. And that electricity is going to be transmitted over these wires. That is known as the cardiac conduction system. These are not real nerves. These are just specialized cardiac muscle tissue that have the ability to start off, so to initiate, and to distribute that action potential. So it's like the heart has its own battery. And the battery, so to speak, is the SA node, known as the sinoatrial node. The SA node, that is considered the pacemaker of the heart, and then the electricity goes down to the atrial syncytium, which is the atrial muscles, and then to what is known as the junctional fibers that leads that electricity to the AV node, which is the atrioventricular node, and then through the AV bundle, and then bundle branches and Purkinje fibers down to the ventricular syncytium. So we'll take a look at that right here in this image. Right, the SA node is in the right atrium. It's all the way on the top. And then you can see the electricity flowing into the atrial syncytium to your AV, to the junctional fibers, and then to the AV node and AV bundle. So that bundle is, or the AV node and AV bundle, that's how the electricity goes from the atrium to the ventricle, and it only allows the electricity to pass in that direction. Electricity in the heart can never go from the ventricles up to the atrium. Okay. And then that bundle or AV bundle or the bundle of His is going to divide into a right branch and a left branch. You can see that each branch is going to conduct the electricity to its corresponding ventricle. And then you can see these little branches kind of going into these muscles known as the papillary muscles, and those are your Purkinje fibers. The cardiac muscles are made in a very unique way. They're organized very uniquely, kind of like in this swirling appearance, so that when it contracts, it literally squeezes and pumps the blood out of the heart. Now we're going to try to understand the electrocardiogram, ECG or EKG, which is basically the recording of the electrical changes that are happening in the myocardium. Know that these electrical changes are not happening in the endo or in the pericardium, it's in the myocardial fibers. And there are different waves that we see. We have a P wave, QRS, and a T wave. And I'm going to show you what that looks like. So this right here is one cardiac cycle. We start off with a P wave, and then we have this QRS complex, and then there's a T wave, and then there is, a little gap here, or that time until another heartbeat occurs. So let's understand what each wave stands for. The P wave stands for atrial depolarization, which means this is when the atrium is depolarizing and it is going to contract. And then you have the QRS complex. That's when this signifies or illustrates the ventricles depolarizing, and that's when ventricular contraction or ventricular systole occurs. The T wave represents ventricular repolarization, where the ventricles are relaxing or going through ventricular diastole. So we mentioned atrial contraction, we mentioned ventricular contraction, and ventricular relaxation, but we did not mention atrial relaxation. The problem with atrial relaxation is that if you guys remember, it happens at the same time as ventricular contraction. And because the ventricles are much thicker, there's lots of electricity coming out of them, and that's what we record. We do not record the atrial relaxation or atrial diastole, but because it kind of gets masked by all of the electricity coming out of the ventricles during their contraction. Arrhythmias, that is altered heart rhythms or irregular heartbeats. Those could either be tachycardia or bradycardia. So tachycardia would be an abnormally fast heartbeat, which is more than 100 per minute. Normal heart rate is between 60 to 90. It's very variable from one person to another. Heart rate at rest more than 100 is known as tachycardia. Less than 60 per minute is known as bradycardia. If it is between 250 to 350 beats per minute, that's known as flutter. Fibrillation, though, are uncoordinated chaotic contractions, which would be more than these 350 beats per minute, which basically the heart is basically just shaking, and there is really no filling and contraction actually occurring. Because it's so fast, not allowing for the chambers to fill up with blood and then contract and push it out. Okay, atrial fibrillation is not life-threatening, but ventricular fibrillation or VFib is. So the thing is that if the SA node cannot work, there is a backup battery, which is your AV node. If the AV node doesn't work, there's another backup, which could be one of the Purkinje fibers can take over. But, in the case of VFib, it could be that maybe somebody has an ectopic pacemaker. So, it's not where the SA node is damaged, the AV node is damaged, and some other cell kind of took over and is now causing too many heartbeats. So that could lead to your VFib. You'd have to return that patient back to normal pacemaking or to the normal heart rate. That could be, through ECT or artificial pacemakers. Eventually, they would have to get an artificial pacemaker in order to prevent that from reoccurring. An ectopic pacemaker, which I kind of already touched on, you've got damage to your SA node, which could lead to other parts of the conduction system taking over. It could be an AV node, it could be a Purkinje fiber, and usually, sometimes if it's the AV node or the Purkinje fiber, these heart rates are going to be slower than the SA node. So the SA node being the pacemaker, it is the strongest of these three batteries. For regulation of the cardiac cycle, so yes, the SA node is your pacemaker, but we sometimes need faster heart rates or slower heart rates depending on your physical activity, depending on body temperature, concentration of ions like potassium and calcium and so on. So we control the SA node through the parasympathetic and sympathetic impulses. Parasympathetic impulses are obviously going to slow down your heart rate. They affect your SA node and AV nodes, while the sympathetic stimulation, that is going to stimulate the heart rate through the stimulation of the SA node, AV node, and the ventricular myocardium. So baroreceptor reflex means that this reflex is initiated or is affected by your blood pressure. And remember, a reflex, it starts off with a receptor. So the receptors are baroreceptors that are found in the arch of the aorta, and we have other receptors here in the carotid artery, and that is known as your carotid sinus. And in your carotid sinus, you have these carotid baroreceptors, so you want to get what the blood pressure is going to be like before the blood actually reaches your brains. And then you've got the aortic baroreceptors, and this is where, as soon as it's pumped out of the left ventricle. Now, these two receptors are going to pick up, changes in, will monitor your blood pressure. So that would be your sensory, or your sensory fibers, and it'll take it to the center, which is the center of the reflex, which is different parts of the CNS. And then depending on what the finding was, so let's say this person has low blood pressure, and that's the impulse that reached the control centers in the CNS. So your motor or your afferent fibers are going to send sympathetic stimulation. So you see that these purple fibers are your sympathetic fibers stimulating the SA node, AV node, and the Purkinje fibers. While if the blood pressure was too high, we got motor fibers, so the parasympathetic, these blue fibers are going to send inhibitory impulses to the SA node and to the AV node. You see here that parasympathetic does not supply the ventricles. There are no parasympathetic or blue fibers reaching the ventricles. Now, the different kinds of blood vessels, we have we've got the arteries. Those are your biggest. And remember, again, by definition, an arteries is any blood vessel that takes blood away from the ventricles or away from the heart. Then you have the arterioles, okay, and those are going to receive the blood from the arteries. These are just smaller or baby arteries, and then it will carry the blood to the capillaries. Capillaries most of our blood vessels are actually capillaries. We have tons of those, and that's where exchange of blood gases happen, so oxygen and carbon dioxide exchange, and these are just made out of very thin layer. It's just one layer of simple squamous epithelium, and then these blood vessels are going to gather up again as venules. Okay, so these venules receive the blood from the capillaries and carry it over to the veins. Those veins are going to carry back all of the blood to the heart. Now here is a little comparison between an artery and a vein. So both blood vessels have the three layers. The outer layer is the tunica externa. Okay, that's made out of connective tissue on the outside of the blood vessel. And then you've got a middle layer that's known as the tunica media, that's made out of smooth muscle fibers that can contract and relax to dilate or to constrict and dilate the blood vessel. And then on the inside, you have that endothelial layer or the tunica interna, and that is made out of simple squamous epithelium. The vein has the exact same all three layers. You can also see that these veins have these valves to prevent, because blood would have to return back, usually against gravity, especially in the lower limb. So in order to prevent stagnation of blood in the veins, and that being pulled down by gravity, there are valves in your veins. You can see that the lumen in the veins is much wider than the lumen in your arteries. And on the other hand, the walls, especially the smooth muscle layer in arteries, is much thicker than that in the veins. This is a little, again, the three layers of the arteries. We have the tunica externa, that's the adventitia, or the outermost layer made out of connective tissue. Then we have the tunica media, it's made out of the smooth muscle fibers, and there's some elastic tissue to kind of withhold all of that blood pressure. And then the tunica interna, or the intima, and that is made out of that endothelial layer of simple squamous epithelium. Next are your arterioles. Those are made out of the same three layers, but as gradually, those three layers tend to gradually disappear up until they totally, the externa and the media totally disappear as we reach the capillaries. And you can see here that, this one is kind of branching out into a capillary, and there is a sphincter. That one smooth muscle known as a precapillary sphincter. The capillaries, those are your smallest diameter blood vessels. It connects these small arterioles to the venules, and this is where the exchange of gas happens. As I said, we gradually, as we go from bigger arteries to smaller arterioles on our way down to the capillaries, these blood vessels are going to lose their tunica externa and tunica media, and we will be left off with only the simple squamous epithelial layer, and that's what the capillaries are made out of. And again, here you can see those little tiny precapillary sphincters. The structure of the capillary, again, that one layer of simple squamous epithelium, and there are little slits in between. And this is an electron microscopic picture of the endothelium. You could see that little slit, or what is known as a fenestration, or a little window, where things might be able to diffuse in or out of the capillary, okay, depending on the size of that molecule. Now, not all organs have the same amount of capillaries, so the capillary arrangement really depends on the metabolic rate of that organ. So for example, muscles that have high metabolic rates, those are going to have a very dense capillary arrangement, while the tissue with lower metabolic rates, like cartilage tissue, for example, have very few capillaries. Now, capillary exchange means that would be the passage of nutrients or metabolic wastes between the blood in the capillaries and the tissue on the outside. The exchange can happen by three different methods: either diffusion, okay, and things that are lipid soluble can just diffuse through that cell membrane of the simple squamous epithelial cells, while things that are water soluble molecules, those would have to be able to fit into these channels and slits that we talked about on the previous slide. Because of the push of blood, and blood has lots of water, that pressure is known as hydrostatic pressure. And that hydrostatic pressure can lead to filtration of things through that membrane. And that hydrostatic pressure is really because of the ventricular contraction. So the stronger the ventricular contraction, the higher the hydrostatic pressure. Osmosis, that is due to the presence of plasma proteins inside of the capillary. Plasma proteins are usually too big, so those are going to remain inside of the capillary. And osmotic pressure is going to pull water into the capillary, so it really opposes filtration. Okay, filtration helps to push things out of the capillary, while osmosis is the power that is going to pull water back into the capillaries. And again, you want to keep that in mind because this is going to really help us, for the rest of this chapter, talking about blood pressure and so on. And it's also going to help when we talk about the lymphatic system and the kidney. So keep that in mind. Again, filtration is due to hydrostatic pressure and it filters things out of the capillary, while osmosis is because of the presence of plasma proteins, and this helps. The osmotic pressure is going to pull water back into the capillaries. So here you can see the capillary exchange. This right here would be the, this is in the air sac. No, this is in the tissue, in the systemic tissue. So you have the oxygenated blood coming in, and then it goes through the capillaries, and then it leaves in these venules as deoxygenated blood. Okay, this would be, this part or this end of the capillary is known as the arterial end of the capillary, while this end of the capillary is known as the venous end. Okay, on the arterial end, there is usually more filtration. Okay, so things are going to be filtered out of the capillary on the arterial end into the interstitial tissue. So this right here is, these are different tissues of the cells, or whatever organ we're in, and filtering things out of the capillary into the interstitial tissue. This is how we make interstitial tissue. Well, on the venous end, any excess interstitial tissue is going to be pulled into the venous end of the capillary, and that is due to the inward force of the osmotic pressure. So again, your arterial end favors filtration due to a higher hydrostatic pressure, while the venous end favors pulling water back in, or reabsorption back into the capillary, and that is due to the higher osmotic pressure. Venules and veins. So on the venules are just smaller veins those take the blood from the capillaries to the bigger veins. And then we already talked about the 3 different layers of veins and, the presence of valves, which is a structure found in veins, not found in arteries. Know that the distribution, this chart here shows you the distribution of blood among the different organs that we've talked about, among the heart and all of your blood vessels. You'll see here that most of the blood is really in the systemic veins. So the systemic veins are considered a reservoir for blood. You see that about 65% of our blood, of those 5 liters of blood that we have, is found in the systemic venous circulation. A little bit on blood vessel disorder. So there's atherosclerosis, which is the deposition of cholesterol plaques in the underneath the endothelium, and it leads to irregularities and is a risk factor for developing blood clots. We've got aneurysm, which is a little bulge found in the wall of an artery, and that is due to the weakness of the tunica media, and it can happen due to high blood pressure. Okay, if that aneurysm is really weakened, and it can burst, leading to internal hemorrhage. Phlebitis is an inflammation of a vein, okay, and varicose veins, that would lead to that is the irregular dilation and of your superficial veins, and it's more common in the lower limbs due to gravity. We'll talk a little bit about arterial blood pressure. So by default, when we say blood pressure, we are talking about the pressure in the arteries. Okay, and arterial blood pressure is defined as the force of blood that it exerts on the inner wall of the blood vessel. So as the ventricles contract, the blood is pushed into the wall, the arteries, and there is a force that is formed, or that is the force pushing on the inner wall of the blood vessel, and that would be your blood pressure. It increases when the ventricles contract, and it falls when the ventricles relax. So when that rise during ventricular contraction, the maximal pressure that can happen during ventricular contraction is known as the systolic blood pressure, while the minimum pressure that remains after, or during ventricular diastole, that would be known as the diastolic blood pressure. The blood pressure is, sorry, you cannot see it because of this, but hopefully you guys can see it on your own slides. The blood pressure is set in terms of a fraction. So we usually, normal, it's a range, but normal blood pressure is 120/80, for example. 120 represents the systolic and 80 represents the diastolic. The difference between these two, so the 120 minus the 80, that is known as your pulse pressure. So that's the difference between systolic and diastolic blood pressures. We measure blood pressure with a sphygmomanometer, and you see here that the blood pressure is highest in the aorta and in the larger arteries. The further away you are from the heart, which is the pump that is the force or pumping all of that blood, you see here that blood pressure tends to go down until where in the vena cava, which is, the biggest veins, the blood pressure in there is almost, it's not zero, but it is very close to zero. So where can we feel arterial pulses? The most common is right here in the radial artery. Okay, but there are other areas where we can detect arterial pulse. We need these other areas because, let's say, for example, somebody comes in and they are a bilateral upper limb amputee. So what are we going to say? Like, I'm sorry, we cannot get your pulse. Okay, that's obviously not the case. There are other places and other areas where we can feel pulses. So there's right here in the front of the elbow, that's the brachial artery, or the carotid artery, which would be on the side of the neck. Facial arteries right at the margin of the mandible. And then there's the temporal artery, which would be on the temples, a little bit anterior to the ears. You feel the femoral artery in the inguinal area, the popliteal artery, which is in the back of the knee. And then there's the dorsalis pedis artery, which is on the upper part of the foot. And the posterior tibial artery, which is behind the lateral malleolus, which is behind the lateral bone on the ankle. So what are the factors that affect or influence arterial blood pressure? There are 5 of them. Okay, so there's blood volume, heart rate and stroke volume, blood viscosity, and peripheral resistance. Okay, all of these are directly proportionate to the blood pressure. So if any of these increases, your blood pressure will also increase. While if any of those decrease, then your blood pressure will also decrease. So we'll kind of take them one at a time. So we'll talk about the blood volume first. So it makes sense that if your blood volume goes up, okay, so instead of having 5 liters of blood, your body has 7 liters, okay? So that is going to obviously increase the blood pressure. And the opposite is true too. So decreased blood volume, for example, due to hemorrhaging, that would decrease the blood pressure. Now we really talk about the heart rate and stroke volume together, okay? Because if you multiply them, it'll give you this really important construct, and that is the cardiac output. So let's give a little bit, define all of these different terms. So the heart rate is the number of beats by the heart per minute. The stroke volume is the volume of blood that enters the arteries when the ventricle contracts, so with each ventricular contraction. And the cardiac output would be the volume of blood discharged from the ventricles per minute. So what you would want to do is you want to multiply the stroke volume, which is how much blood comes out of each stroke of the ventricle times the heart rate. Okay, that will give you how much blood was pumped out of the heart per minute. You don't really have to know these numbers because obviously these numbers are very, can change, but you definitely do have to know that equation. It's extremely important. So any increase in stroke volume or heart rate or cardiac output, that can lead to increase in blood pressure. The peripheral resistance, which again is that force of friction that is happening on the between the wall of the blood vessel and between the blood. Okay, any increase in peripheral resistance can lead to increase in blood pressure. So vasoconstriction increases peripheral resistance, and that is going to in turn increase blood pressure. Viscosity really talks about the thickness of blood. Okay, so let's say somebody is dehydrated, okay, and that is going to lead to increased viscosity of the blood. That increases the resistance to the blood flow. That is going to increase blood pressure as well. Okay, another example would be anemia. So anemic patients have thinner blood. Okay, so there's lower concentration of your RBCs and lower blood viscosity, which is going to lower the blood pressure. So a little bit here on how we how the heart kind of controls the blood pressure. Our blood pressure is obviously not constant throughout the day, it goes up and down. So what is really the mechanism of all of this? Okay, so let's take a scenario where the baroreceptors in the aortic artery or the carotid sinus pick up that there is an increase in blood pressure. Okay, so that would be your sensory neurons that are going to go to your central nervous system, and they are going to the effectors, which would be your blood vessels and the heart. So on the heart is going to decrease the heart rate, it'll decrease the stroke volume, and in the blood vessels, it is going to dilate them. Now, both of these are going to lead to the decrease of blood pressure and returning it to normal. Now, the opposite scenario would be if the blood pressure goes down, that is also going to be picked. Now, the other scenario would be low blood pressure, where, again, picked up by the baroreceptors in the aortic arch or in the carotid sinus. That is going to lead to sympathetic stimulation of the blood vessels, leading to their constriction, and sympathetic stimulation of the heart to increase the heart rate and cardiac output. And both, the action of both of these is going to increase the blood pressure back up to normal. So a little talk about hypertension. Hypertension is really known also as the silent killer because a lot of times people are walking around with high blood pressure and they don't even know it. Okay, so they might not even have any symptoms. It is caused sometimes unknown, kind of sometimes just runs in families. There are predisposing or risk factors like increased sodium or salt intake. Psychological stress for long periods of time can activate the sympathetic nervous system. Obesity can increase the peripheral resistance in the blood vessels. And then there's kidney disease, and the kidneys, the mediation of this is via the renin-angiotensin system. Okay, high blood pressure can lead to also is a risk factor for the formation of atherosclerosis, risk factors for stroke and MIs or myocardial infarctions. So this is one of the things that you really want to prevent and not wait until the patient comes in and is diagnosed with it to treat it. It's more of a preventative measures for healthy diet, weight, regular exercise, and to limit their salt intake. And treatment can be, there's a whole variety of treatments out there, but it's usually diuretics and sympathetic inhibitors. For the venous blood flow, okay, so how is it, in arteries, we have that higher pressure and blood is kind of pushed through those arteries. So what about in veins, where you saw in that graph that sometimes the pressure is really low in veins and it has to travel for long periods of time, sometimes even against gravity. So there are some things to help that to occur. First off, you do have those valves to prevent, the blood from kind of going back or pooling back down. But the most important of these are the skeletal muscle contractions. And that is why prolonged standing without contracting your muscles That can lead to edema, which is swelling of the lower limbs, and varicose veins, while walking does not. So skeletal muscle contraction assists venous return. Breathing movement. So as we inhale, that inhalation kind of works as kind of like a vacuum, okay, kind of like helping in the suction of the venous blood back to the heart. There's also vasoconstriction of veins, but the two most important ones are your skeletal muscle contractions and breathing movements. Central venous pressure, that is the pressure of the right atrium. Okay, so all of the blood is going to be collected, superior and inferior vena cava, and then it's going to be dumped into the right atrium. The pressure in the right atrium is known as the central venous pressure. In cases of right-sided heart failure, okay, that could lead to the increase of pressure in the right atrium. So there's an increase of CVP, or increased central venous pressure, and that can lead to a backup of blood in the superior and the inferior vena cava. And you can see that in some of the veins, for example, in the jugular veins in the neck. It can also lead to backup even in the veins of the lower limbs, and that can lead to edema, pitting edema, which means that if you press on it and you let go, you can still see that area where you pressed. So what are the advantages of exercising, and how does it affect the cardiovascular system? It increases your pumping efficiency, it increases hemoglobin concentration, the number of mitochondria in general in the different cells of the body. It helps enlarge the heart about 40% or more in a good way, not in a bad way. It increases your stroke volume, and more importantly, it decreases your heart rate and blood pressure. So a low heart rate at rest is a healthy indicator. Okay, so for example, athletes, they would have a low heart rate at rest, lower than the rest of the population. That is because they have a heart that is more efficient, so it can perform the exact same function, but at a lower rate, with lower heart rates. Okay. In order for exercise to be aerobic exercise and benefit the cardiovascular system, you want to do aerobic exercise. It lasts to be at least 3 to 4 times a week, and it lasts about 30, half an hour to an hour per setting. And you want your heart rate to go up to about the easiest way to calculate it would be 220 minus your age. Lifespan changes that can happen to the cardiovascular system. We kind of talked about it and touched on some of these as we were going. So there could be cholesterol deposition in the blood vessels, narrowing of the coronary arteries due to cholesterol deposition and atherosclerosis. The cardiac muscles, the efficiency kind of declines over the years, increasing the fibrous connective tissue in the heart, and that is going to limit the contraction and the relaxation abilities of the ventricles, increase in the adipose tissue. The high blood pressure can lead to thickening of the ventricles and the heart valves, decrease in resting heart rate, but in an unhealthy way as we age, because we still need the normal heart rate, which means technically that at this rate, the heart is not performing its function. In athletes, it was performing its function at a low rate. As we age, the resting heart rate will go down, but our needs are the same. And then a decrease in arterial elasticity. So together with the cholesterol deposition, that can lead to high blood pressure and strokes. There is CAD, or coronary artery disease, which again involves deposition of cholesterol on the inner parts of the coronary arteries. It can lead to the obstruction of the coronary arteries and oxygen deficiency, and can lead to heart attacks. The risk factors would be high cholesterol levels and hypertension. So there is that triad of hypertension, diabetes, and hypercholesterolemia. Those three are, red flags or risk factors, very dangerous risk factors for developing coronary artery disease. The treatments include percutaneous transluminal. Unfortunately, we can't see it because of this, but that would be the, so I kind of moved things around so you can kind of see how these work. So PTCA, or the percutaneous transluminal coronary angioplasty, which are these, this image right here. And it really, includes the insertion of that balloon, and you inflate the balloon a little bit, and that tends to open up the blood vessel. Another more permanent solution would be a coronary bypass. We'll take a graft from the saphenous vein, which is a vein in the lower limb, and use it to kind of bridge, to bypass the area of the occlusion or where the clot is. Okay, this concludes chapter 15.